All right, well, welcome to this webinar. Thanks for showing up. We've got some exciting things to go through. I want to go through some thyroid stuff. There's a lot of misconceptions about the thyroid, and I will tell you the biggest misconception is, and patients get so frustrated about this, is that they'll come in and they'll be like, okay, I went to the doctor, I've been to 3 doctors, I know I have a thyroid problem because I have all the symptoms, but I've been told that my thyroid is normal. That can actually be really frustrating for people because people are smart and they know what's going on, and they can see these things. So what I wanted to do here is I wanted to take just a little bit of time and go through how to spot these hidden thyroid problems. So let's get right into it. We've got a lot to do, so let's get right to it. So there's 6 major patterns that you're going to find for hypothyroid, and only one of them is primary, and so only one of them is going to show up at a traditional medical doctor's office. So about 80 to 90% of low thyroid function is going to be missed by the traditional medical doctor, and the reason why is because only about 10 to 20% of these are going to be primary, and I'm going to show you what I mean by that. Thyroid is basically a canary in the coal mine. What does that mean? That means that when they used to put canaries in coal mines before they could measure gases. And so when the canary dies, that means, uh-oh, watch out, here we go. So when you see somebody has low functioning thyroid, it's generally, not always, but it's generally, if it's in that 80%, 90% factor that it's secondary, it's coming from some other reason. And it's just a sign that something else is going on, or some things else are going on. So I like this. This means something, but I can't remember what when the canary's died. That's not good. All right, so let's do a quick clinical walkthrough. All right, history. 5 most common symptoms that somebody has a thyroid problems: fatigue, weight gain, brain fog, constipation, dry skin. They might not have all 5 of those, but man, a lot of times they do. So somebody comes in and they have fatigue and weight gain. Particularly, they'll come in and a lot of times they'll say, man, I'm on a low-calorie diet. I cannot lose weight no matter what. And they have 10 to 20 pounds, 30 pounds they just can't get rid of, and they're eating the same as they used to. Brain fog is common. As it turns out, there's the T3 is, which is the active form of the thyroid, is very important for the production of something called acetylcholine. Acetylcholine is that chemical neurotransmitter in the brain that actually gives processing speed to the brain. When you start having low acetylcholine, your brain gets slower. When your brain gets slower, you start having things like brain fog. In fact, Alzheimer's, dementia, and these factors, they have that in common as well. Low acetylcholine, not necessarily due to thyroid. Constipation, everything moves slower when you have slow thyroid. So if you have poor thyroid function, you can potentially have constipation. Why? Because the bowels are a big muscle. The colon is a big muscle. And if you don't have enough thyroid support, then that muscle function is not going to do its job. And dry skin, here's another thing, just poor metabolism. Your body's not recreating itself well. You can see the reflection of somebody's health by looking at their hair, looking at their fingernails, looking at their skin. These are all expressions of someone's health. Observations. You can see the thin, coarse hair, that swelling underneath the eyes called periorbital edema, lateral third of the eyebrows. So you take the corner of the eye right here, and if you go out that way, 1/3 of the eyebrow should be out there. And if it's very diminished or gone, that is a sign of low metabolism. That's also a sign of low thyroid. So those are all things. So we'll walk through each one of these. Now, I wanted to say something real quick about when we're looking at anything. All right. So when we are trying to make an assessment to figure out somebody has low functioning thyroid, we don't necessarily look at one thing and say, aha, you've got a poor functioning thyroid. The exception would be somebody with a TSH out of whack. But generally, what we're looking for when we're doing an assessment on somebody are patterns. What do I mean by patterns? Well, let's say somebody comes in, they're fatigued, they have weight gain and brain fog. And we also notice that they've got lateral third of the eyebrow gone, and their hair is a little more coarse. And then we notice a few things in the lab. We put all of those things together, and it fits a pattern. And when it fits a pattern, then we can be assured that, okay, this looks like this is probably going to be this is going to fit a pattern of a low functioning thyroid. So that's how we do it. All right, so let's take another look. Let's go further. When you look at blood chemistry, there are going to be some things that can show up on the blood work. They might not show up on the blood work, but if you see 2 or 3 of these things or more, it starts building, as I said, that pattern to get us an idea. Is there a thyroid issue going on? Well, let's walk through this just a little bit. All right, so one of the things that happens when you have a low functioning thyroid is this. You can't really separate liver function from thyroid function. If you have poor thyroid function, you're going to have a slow liver and a slow brain. Why is that? Well, the most highly metabolically active organs in the body are going to be the liver and the brain. So the brain's doing all of its stuff, but the liver's doing all of its stuff. It's processing the fats, processing hormones, processing proteins, processing sugar, eliminating waste, getting rid of toxins. It's doing all these different things. So it takes a lot of metabolic strength to be able to do that. So thyroid is what gives it that metabolic strength. And I'm going to back up just a little bit before I go through the liver and say one more thing about it. All right, so actually, forgive me. Let me move on because there's a better place for me to put that in. All right, so liver. Let's look at the liver. When you have low functioning thyroid, you're going to have a sluggish liver. When you have a sluggish liver, you don't process cholesterol well, and it basically just backs up and goes high in the blood. So many high cholesterol cases are from low functioning thyroid. Certainly not all of them, but many of them are. Now, there's a hallmark of a low thyroid ratio, and it goes like this. If we look at cholesterol to HDL ratio, when that cholesterol to HDL ratio goes over 5, then we start thinking about cardiovascular considerations. Of course, if you've been through my cardiovascular courses, there's a lot more in depth than just looking at this number. So don't just be fooled by this number. But certainly, if we see a cholesterol to HDL ratio that's above 5, we do start thinking about maybe cardiovascular stuff. When cholesterol to HDL ratio goes below 3.1, we start thinking about immune dysregulation. So yeah, it's really true. HDL cholesterol can be too high. When it is, that ratio goes lower. That's immune dysregulation. But when you've got a big old fatty liver, metabolic syndrome, your HDL is going to drop, and then this number is going to go higher. That is akin to cardiovascular. That matches the cardiovascular pattern. Now, going back to thyroid. Many times, when somebody has a low thyroid and they have sky-high cholesterol, you'll look at this ratio, cholesterol to HDL ratio, and it will be normal. So you could have somebody with 300 cholesterol, and then you find out that they've got like 75 HDL. And if they have 75 HDL, then that ratio would be 4. And that would be completely within that normal range. So elevated cholesterol. Now, my caveat to that is this. Some people, there's no rule that says that you might not have low functioning thyroid at the same time you have a big old fatty liver, metabolic syndrome, cardiovascular disease, that kind of thing. So elevated cholesterol is a common, low thyroid is a common cause of elevated cholesterol. These people should not be on statins. This is not what the problem is. How many people go to their doctor and they just get slapped on some statins without any consideration? They're not looking at these patterns. They didn't look at the cholesterol HDL ratio. They didn't look at the thyroid numbers. They didn't look at it clinically. They saw that somebody was tired, brain fog, constipation. Maybe they wrote that on the forms, but they saw cholesterol over 200 and whammo, just like a sledgehammer, they want to beat that cholesterol in submission. Very, very poor workup. All right, so next, depressed or elevated alkaline phosphatase. Well, let's take a moment and talk about this. So as it turns out, alkaline phosphatase is an enzyme that is found in the bones. And so as it turns out, your bones are turning over all the time. I've heard of something like every 7 years you have a new bones. I don't know. I don't know that number. I suspect that you probably are recreating your bones a little quicker than that, but I'm not an expert at that. But I do know this. There is an enzyme in your bones that is part of the growing process. And so when your bones are turning over, you're going to see more of the alkaline phosphatase. That's one of the things alkaline phosphatase does. So when you have low alkaline phosphatase, lower than 60, a very common reason for being lower than 60 is low metabolism, which can come from low thyroid. And it makes sense, doesn't it? Because if you have low functioning thyroid, you're going to have not only low metabolism in the liver, but you have low metabolism in the bones. So it's going to make that number go down lower than 60. Here again, here's my encouragement. You don't just look at alkaline phosphatase and see somebody at 50 or 52 or 54 or whatever and say, you got low thyroid. You got to look at the whole package, right? You look for a pattern. Are they tired? Do they have weight gain? Do they have brain fog? Are they constipated? Lateral third of the eyebrow gone. Do they have elevated cholesterol? And they have low alkaline phosphatase? Then I could be confident in saying, look, this fits a pattern of low functioning thyroid, and more things that you see that fit that pattern, the more confidence that you have the correct assessment. Now, the next thing about it is kind of funny, but alkaline phosphatase also is found in this. This is the liver, and this is the gallbladder. It's found in this hepatobiliary bile flow. Okay, so if you have an obstructed bile duct, your alkaline phosphatase can go through the roof. Because if it's clogged and your bile's not flowing, it will elevate that alkaline phosphatase. It's part of how you get rid of alkaline phosphatase in your body. So it's floating around the blood, you got to get rid of it, it goes to the liver, and it goes through the bile. But guess what? If your bile gets obstructed, it goes back and backs up in the blood and goes high. So this has been my observation. You can take it for what it's worth. But I have found that anytime alkaline phosphatase gets over 80, it fits a pattern of poor bile flow. Now, this is like 2.0, I'm past 1.0 here, but low thyroid is one of the more common reasons for sluggish bile flow. So if you have somebody has poor bile flow, for whatever reason, poor gallbladder function, that's also going to be one of those clinical things. You're going to look and say, do they have low functioning thyroid? And you're going to look for all these patterns. All right, so that's kind of back and forth. Let's move on. So elevated bilirubin kind of goes the same way. If you have sluggish bile, you're not getting the bile through, the bilirubin, which is part of the bile, can back up in the blood. By the way, cholesterol is supposed to go through the bile and bilirubin is supposed to go through the bile. So both of those can potentially be high if you have sluggish bile flow. Sluggish bile flow is very common with low function thyroid because, as we said, it's the liver is the most hyper metabolic organ in the body, and you can literally do a HIDA scan and you can watch the gallbladder moving. So it's very active. So when you have poor thyroid function, you're just not going to move the bile as fast, and the bile needs to move like a river, not like a pond. So if your bile flow is not flowing really well, then it gets gunked up, cholesterol comes out of solution, now you start building sludge, that sludge turns to stone, yuck, 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 yuck. All right, so the next thing, depressed white blood cells. Now, I don't really want you to major on this one too much because there's so many things that's going to lower that white blood cell count that I don't want to look at it and say, low white blood cell count, you have hypothyroid. But anything under 5 would definitely fit a pattern. Here's one you want to watch out for, the size of the red blood cells. So when you see MCV, mean corpuscular volume, you'll see that in your CBC. When that number hits 100 or higher, you're going to think one of three things. That is usually an anemia. It's going to be in a form of anemia, and it's going to be either low B12, low folate, or low thyroid. These are the three things that can cause you to have elevated MCV in your blood, right? Now, you can be completely way inflamed and infection, and that can do it. There's a lot of other things can do it. But I will tell you, if you have an MCV that is 100 or above, these are the three top vote getters. So you want to evaluate. Are you low in B12, low in folate, low in thyroid? How would you do that clinically? Well, it'd be very simple. What you would do is you'd say, oh, you have an MCV that's 102. Let's look and see what pattern is merging. You say, oh, fatigue, weight gain, constipation, lateral third of the eyebrow is gone, dry skin, cholesterol's 240, alkaline phosphatase is 95. Then we see MCV is over 100. You're like, yeah, that might fit a pattern of low functioning thyroid. Next one, decreased platelets. Now remember that in your liver, you make something called thrombopoietin. Thrombopoietin goes to the bone marrow and activates you to make platelets. So if you have sluggish liver metabolism, you're not going to make as much as that thrombopoietin, and that can have you have lower platelet counts, 160 or lower. Any pattern of blood sugar dysregulation, primarily hypoglycemia, but can also be just any kind of insulin resistance, which could be a form of the hypoglycemia. But anything with hypoglycemia, when you drop blood sugar, you can't separate blood sugar from cortisol. Cortisol is your major hormone that regulates blood sugar. So if your blood sugar is bouncing around, your cortisol is bouncing around. If your cortisol is bouncing around, your progesterone and your thyroid's bouncing around. So you can't have blood sugar dysregulation without having some kind of dysfunction in thyroid work. So a lot of times people will have low functioning thyroid and they'll go to the medical doctor and they'll check their TSH and T4 and they'll say, yeah, we don't see anything, there's nothing here. And they've got hypoglycemia, and the hypoglycemia, functional reactive hypoglycemia, and it's driving the low functioning thyroid. That's a common. There's other things too, but that's just a common presentation. All right, so LDH, anything lower than 140 is going to be something. Let's take a look at this. All right, so here is, let's make this a glucose molecule. Glucose goes into the cells and spits out energy. Well, you have an enzyme that's called lactate dehydrogenase, and its job is to convert the pyruvate. Once it gets into here, I don't get too far in the weeds. I like biochemistry, but I don't want to bore everybody and everybody check out. So, but at risk of that, let's just say this. When glucose goes into the cell, it converts into pyruvate. Pyruvate goes down into the Krebs cycle, and you do all the things the Krebs cycle does. But there's another pathway, right? That other pathway is to go from pyruvate to lactate. Well, when you do that, you have to have LDH. There's a principle in nature that goes this way. If you don't use something, you don't make it. If you go to the gym and you do bicep curls, you're going to build your bicep muscle. If you never go to the gym, you won't build your muscles. So this is just how it goes. So the thing is if your LDH goes 140 or lower, it's a sign that there's times during the day you don't have enough sugar in your blood. Now, guess what? You might be on a ketogenic diet, a carnivore diet. You might be burning a lot of fat for fuel, and then that equation doesn't work because we wouldn't expect you to be burning a lot of sugar because you're burning more fat. But if you're eating SAD, the standard American diet, and you have an LDH that's lower than 140, I will assure you, you're having reactive hypoglycemia. I know what these CGMs are saying, chronic, you're looking at the glucose control in the monitor. You say, no, it's not dipping. I can tell you there's something wrong with with making that evaluation from that. If you have an LDH that's lower than 140, I will assure you, you have blocking sugar, especially if somebody's on the SAT. They're having sugar that's crashing down, and they're having problems. Another one is this: if your cholesterol to triglyceride ratio, it should be 2 to 1. So your cholesterol, to triglyceride ratio should be 2 to 1. So if you have cholesterol to 180, I would expect your triglycerides to be about 90. That would be normal sugar metabolism. Now keep in mind, tri means 3, and what a triglyceride is it's 3 fat molecules wrapped around a sugar molecule, glucose. So when you start having times during the day when there's not enough sugar in your blood because you're crashing, then what you're going to do is you're going to suck up some of those triglycerides, and you're going to use that glucose for fuel in there, and now your ratio is going to be 180 to 60. So a lot of times what you'll see with people who are reactive hypoglycemics, this functional reactive hypoglycemia, is you're going to see that they have a 3 to 1 pattern or even more than that. So those are the 2 blood things. There's a lot of clinical signs that you can see with that, but I'll leave it there because we got too much other stuff to do. Elevated LDH can also be linked to hypothyroid, so can creatine kinase. All right, so let's move on. Here are my primaries. So let's take you through the thyroid loop. So here is the brain, here's the nose, the mouth, here's the thyroid. Here's the most important thing to understand about thyroid function, and that's this. It's a basic thing. The thyroid cannot think for itself. It only does what the brain tells it to do, right? So we have our pituitary right here. It sends down a message to the thyroid in the form of thyroid stimulating hormone. Thyroid stimulating hormone activates your thyrocytes in these little follicles to make that protein and to kick out the T4, primarily T4, but some T3. You're going to primarily kick out T4. T4 is a 2-ring structure that has 4 iodines stuck to it. You don't use it, only about 10, it only has about 10% of the potency of T3, but you use it for a very important reason. It transports through the body really well. So once you make it, it can circulate until it gets to the liver, the lungs, the eyeballs, or wherever it needs to go for your function. And then when it gets into those cells, you've got an enzyme called 5' deiodinase. 5' deiodinase that basically takes that iodine off, and it becomes T3. Now keep in mind, the half-life of T4 is about 2 weeks, so that stays in the system pretty well. The half-life of T3 is only about an hour, maybe up to 24 hours, right? There's different conjecture on that. But regardless, T3 does this, and this is really important to understand. This is the missed feature on thyroid function in a lot of cases. It goes to your DNA. Now watch this. Thyroid and cortisol are the only 2 hormones that go straight to your DNA. All the rest of them are on receptors on the outside of the cell. But thyroid and cortisol go straight to the DNA. And what does it do? It activates the DNA to produce proteins, the proteins that make it work. Now, guess what? Guess who else in the cell has a DNA? And it's a DNA unique to itself. That's the mitochondria. The mitochondria has the DNA. So guess what? The thyroid communicates with the mitochondria and activates that mitochondria to work. Here's the piece that makes people tired. Here's the piece that makes people heavy, right? That's the piece. All right, so the next thing is your T4 and your T3 feed back to primarily the pituitary and the hypothalamus. So the brain knows how much is in the body, and then it accordingly sends down the TSH. So that's kind of the thyroid, that's the thyroid cycle. Now, when we get to the patterns, which I want to get to, then I'm going to describe how each one plays a role within this model. So let's move on. All right, so there are 6 primary patterns. I'm looking over my shoulder because my clock is there. They want to see where I'm at. There are 6 primary patterns. There's a lot of patterns. There's like 30 different if you want to nuance it out. But there's 6 major categories of patterns for low functioning thyroid. The first is primary. We're going to see an elevated TSH. Most of these, not all of them, are from Hashimoto's. Somebody could have a thyroid removed and have elevated TSH. Somebody could have just a poor thyroid function and have an elevated TSH. But most of these are going to be Hashimoto's. I don't have a number. People ask me, what about the number? Well, I'm going to tell you this. Unless if somebody has an intact thyroid and the TSH is like 8 or 9 or 10, the higher it gets, the more suspicious it is Hashimoto's. I've seen people with TSHs at 8 and it not be Hashimoto's. I don't think I've ever seen somebody that had an intact thyroid that had a TSH that was like over 10 that wasn't Hashimoto's, and I might have. I don't know that. Don't make a rule or a law of that. I'm just saying the higher your TSH is, the more suspicious you're going to be that this is going to be Hashimoto's. So you're going to do it. I remember when I first started doing the DABCI work years ago, and I had a lady came in that she had infertility. She was healthy. She felt great. No tiredness. Everything's wonderful, wonderful, wonderful. But she had like 2 or 3 miscarriages, and she's like, I don't know what's going on. Well, I did just a regular blood test on her, kind of a standard what I was doing at the time, and her TSH was, I don't remember, it was like over 10. So I was like, well, I wonder if she has Hashimoto's, and sure enough, she did, and that was what was causing infertility. But I didn't catch it from any of the patterns. I just saw, oh, that's a high TSH. We should go ahead and check for Hashimoto's, and sure enough, that's what it was. All right, so then we have the secondary. We have hypoglycemia, tertiary. Let's just walk through these. It'd be better to do that. All right, so far we've talked about some of the symptoms you're going to see, and I talked about indirect blood stuff you're going to see, and I talked about the thyroid cycle. I'm going to take just a detour very quickly. We're not going to do this long at all because I got to get to these patterns, but I want to show you, here's some of the presentations you may see on a person. One is you see, well, I don't know how much you can see of that, but you can see that looks like maybe coarse hair, kind of coarse skin, periorbital edema. You see the kind of the edema, and there's not a gut. Yeah, you see the edema down at the bottom there. That's periorbital edema. The eyebrows are thin, so coarse hair and so on and so forth. All right, so one way we look at this is we draw a line right here from the the lateral margin of the orbit, and you go 1/3 this way. If it's diminished or gone, that's an indicator of a low metabolism. Doesn't mean low thyroid, but low thyroid is just the most common thing that can go in that group. Here's one. Look at that. You can see that on a fast riding horse, right? So also they can have a swelling down there that you'll see. Sometimes they complain of having swallowing problems, right? Here's a big one, scalloped tongue. They stick their tongue out. One thing that a low thyroid will do is it will make your tongue inflamed, and it'll push it against the bottom teeth, and then we see the scalloping. Now, small scalloping, this is my observation just after years of looking at it. Smaller scalloping is usually associated with GI inflammation, but you get the deeper grooved scalloping, usually associated with low thyroid, and mostly, not all, but mostly you'll see a Hashimoto's case there. So also, this is that myxedema where you don't have, you don't have swelling in the ankles, but it's tibial edema, myxedema. That could be dry skin, right? Fungal toes, poor capillary, because you can have low circulation with low thyroid. All right, loss of hair, dry skin, dry heels, you want to do that. Okay, so this is more of a deeper scalloping that's associated with a thyroid issue. That is kind of lighter, but that can still be thyroid. But when I see it kind of not as defined, like you see how defined that is? When it's less defined, a lot of times I find that associated with GI inflammation. That's pretty defined right there. All right, that's superior orbital edema, lateral third eyebrow, coarse hair. All right. One of the things you'll see is diminished reflexes when you're doing your physical exam. Achilles heel is the one that's the most classic. A sluggish Achilles heel, a diminished reflex in the Achilles. I say heel, not heel, but in the Achilles tendon, if you have a decreased reflex there, that is common. Vowel sounds can be decreased. Why? Because sluggish metabolism. Also, they can be tender right where that gallbladder lives. Why? Because thyroid has a tendency to give you sluggish bile flow, and that can inflame the liver. So you get right up underneath there and push in there, and you can sometimes feel that. All right, let's move on. So to the 6 patterns. Here we go. Let's talk about primary hypothyroid. It's the only true thyroid dysfunction and the only one that can effectively be managed by thyroid replacement hormone. Now, I will tell you this. If somebody comes in and they're on levothyroxine, or they're on natural thyroid, or they're on Armour, or they're da-da-da, or whatever they're on, if they are on an appropriate dose and they feel like it's doing them good, everything's going well, I'm not touching it. And the reason why is because out of all the medications out there, the thyroid medication, this is just my observation, seems to be like the least problematic. So if somebody's doing good, don't change courses on them. I don't suggest you do that. So, okay. So the next thing I'll say is this. Sometimes people have Hashimoto's and they have this primary, and 1 month they feel great, the next month they don't, and it's bouncing around. Well, here's the deal. They will go to their doctor, and based upon what the TSH is, they may change the dosage. The more you change the dosage and the more often you change dosage of medication, the more problems you're going to have. So here's what I tell patients. You first have to stabilize your physiology before you start yanking that medication around. You got to make sure your blood sugar is good, make sure your GI tract's working good, your liver's working good, you're healthy otherwise, the bail them out stuff that we always talk about. Got to make sure all that stuff is working right the best you can. You got to stabilize physiology. Then you're going to be at a more stable place that the medication is going to be seen for what it is. It's either going to work or it's not. And then you have to work through those details. All right, so let's talk about the primary. Here's the case primary. I'm sorry if you can't see that very well, but 58-year-old female comes in complaining of thyroid and, fairly classic. Here we go with cholesterol 227, right? But guess what? She has, remember, your cholesterol to triglyceride ratio, when it goes, it should be 2 to 1. So if her cholesterol is 227, I would expect about 110, 120 on triglycerides if she had good sugar metabolism. She doesn't. So it's 391. So she's not like 2 to 1, she's almost 1 to 2. So what that tells me is this is a classic case of insulin resistance. Remember, there's another ratio. We look at triglyceride to HDL ratio, and that should be 3 or less. And I don't know what that is right there, but that's actually approaching 10. So it's about 9 or 10. So this lady's way down the chart in insulin resistance. So therefore, we're kind of seeing more of this cardiovascular pattern, cholesterol to HDL ratio, but that doesn't negate the fact that she might have a thyroid issue. Now look at this. TSH is 34.47. So we almost always see somebody with that high of TSH that they're going to be a Hashimoto's case. So if you look at this right here, T4 should be 6.5. That's what comes out, 6.5 to 12. That's what comes out of your thyroid. And this lady's at 4.3. So that's really just very inadequate. Free unbound, T4 that comes out should be 1.1 to 1.0, 1.1, 0.7. So that thyroid is just not putting out. And here's the reason. She has thyroid peroxidase antibodies. This is a Hashimoto's case. All right, so, okay. So here's another case here, 217. Oh, I think this is probably a pre-post. That's all. Um, so this is after working on her cholesterol's down to, and you see that right there. She was 391 on that, and that's come down to 122. So she's certain her sugar metabolism is certainly better. And her Hashimoto's number, her antibody was 109 there, and the first antibody was 711. So just showing that progression of time. It's a year or two. So it was, whatever that was. I just put that in there. All right. I don't want to make a big deal out of that because I want to get to these patterns. All right. So secondary. Here's a case study. What is secondary? Well, let's define it first, and then we'll do the study. All right. So this is a very common one right here, and I'll show you one of the mechanisms that does it. So somebody has reactive hypoglycemia, and so their glucose is dropping through the day. So the pituitary sends an alarm called ACTH to the adrenals to kick out cortisol, and cortisol has a main function of regulating three main things. It's going to regulate blood sugar, it's going to regulate blood pressure, and it's going to regulate your immune system. So what happens when cortisol goes up, you get more sugar and oxygen to the brain. Cortisol is a stress hormone. When you're under stress, you need more energy for the brain. So that's the reason why that does that. And you don't need to be bothered with an immune system that's overreactive. So what happens when you get under stress, your immune system goes way down. So you're not fighting anything. You're just dealing with the stress and you have the energy for the stress. So that's a basic mechanism. But when somebody has a dropping blood sugar through the day, crashing blood sugar through the day, what's going to happen is they're going to make cortisol. Cortisol gets sugar to the brain. But here's what happens. Cortisol also feeds back to the pituitary. Pituitary says, okay, I got the signal, and shuts it off. It's a negative feedback. But over time, the pituitary doesn't like to see all that cortisol. So you develop what's called pituitary fatigue. All right. So one of the hallmarks of pituitary fatigue is now these other guys, luteinizing hormone, which is what kicks in ovulation for ladies, what makes testosterone for men, FSH, which makes sperm for men, makes the egg for the woman, growth hormone, and TSH. All of these can go low or go lower, even in the functional range, for people with this reactive hypoglycemia that's going on and on and on and on. And here's a classic hallmark. Perfect TSH is going to be 1.8 to 3.0. With these people with pituitary fatigue, a lot of times you're going to see that TSH 1.2 to 1.8. So it's going to be a secondary slowing of that thyroid function. And they might even have normal or normal low T4. It might be functionally low or on the margin of functionally low, and they still are going to have hypothyroid symptoms. And as soon as the blood sugar is corrected, or whatever's driving the hypoglycemia, or whatever's driving the pituitary fatigue, once that's addressed, then things start getting better. So the thyroid symptoms get better. All right, so here we go. Splitting type headaches, 8 to 12 days, 15 days a month. Fatigue that has worsened over the last 3 years. She's been on simvastatin for the past 3 years. It did not lower cholesterol, and patient stopped on her own 3 months ago. All right, so physical exam. She had the scalloping on the tongue, pupillary reflex off, gag reflex, enlarged right side thyroid was large. A lot of times you'll feel that periorbital edema, and that's good. All right, so what do we have? Well, look at that cholesterol right there. So this is kind of a classic. See, you look at the cholesterol to HDL ratio right down here. It's right there in that normal zone. Here again, you're always looking for patterns, but that definitely fits a pattern of a elevated cholesterol coming from a low thyroid. Definitely fits the pattern there. All right, so here's something very good or very interesting. So LD, if you remember, I said any LD that's lower than 140 is a clinically is a pattern that fits hypoglycemia, and she has 123. So there's some hypoglycemia going on there more than likely, a reactive, functional reactive hypoglycemia. And here we go. TSH is right in that secondary pituitary fatigue reason for hypothyroid. All right, so and so you look for that pattern. If you see a TSH that's going to be lower, oh my goodness, I'm about to run out of energy here. If you see a TSH that is lower, that's in that zone of 1.2 to 1.8, I want you to start looking for this pattern of secondary. And how are you going to look for that? Look for the signs and symptoms of crashing blood sugar. You want to look at your cholesterol to triglyceride ratio. Is it 3 to 1? Look at your LDH. Excuse me for just a moment. Okay, that was fun. All right. So I didn't realize my computer was so low. Sorry about that. All right. Y'all with me here? I'm going to see what we got going, make sure we're not missing anybody. Okay. All right. Very good. Perfect. All right. I got a question here. I might see if I can answer it. I may see if I can look at it. And if I can't, I won't. All right. Man, I can't. I don't know that I can read those questions. All right. Very sorry. I usually have somebody helping me, not on this, but when we do our seminars for the DABCI program. All right. So let's go to the third one. All right. So hypothyroid, tertiary to hypothalamic hypofunction. This is also another one that we're going to see. This one basically comes from an infection. So let me show you what this looks like. All right. So we have brain. This is the nose, the mouth, thyroid. Thyroid kicks out T4, and then we go to T3. We feed back to the brain, and so on and so forth, right? So we have the hypothalamus right here. We have the pituitary right there, and then we have the TSH. Now, when we have a secondary hypothyroid, we're going to see the TSH get in that zone of 1.2 to 1.8. Normal is going to be 1.8, or perfect, I should say, to 3.0. Now, that's because it's a pituitary fatigue. But viruses in particular, but bacteria can do it as well. Infections can communicate with the hypothalamus and go upstream a little bit further. The hypothalamus sends thyroid releasing hormone down to the pituitary, and then the pituitary kicks out TSH. So if an infection lands on the hypothalamus, it slows these gears down even more. Now think about this. When you have an infection, innately, what do you need to do? You need to lay down and rest. You're going to lay down and rest so your body can heal. Well, this is one of the mechanisms that happens. That hypothalamus gets the virus or whatever the microbe is, and it slows the gear, and so we'll see these TSHs go below 1. They don't usually go below 0.2 or 0.3 or 0.2, but they're going to be somewhere in that zone, usually around 0.4, 0.5, 0.8, somewhere in that zone. Now, I have found people have chronic infections, and this was the only thing that first clued me into it. I am a big believer in this analyte, and you'd be amazed how many times I've had people come in with chronic infections. They've been to their medical doctor, and the medical doctor says, and the clinical range TSH, I'm sorry, I should say that, set it up, 0.5 to 4.5. So somebody will come in and their TSH is 0.4. They're tired, they don't feel well, they're sick, and the medical doctor will say, you have hyperthyroid because your TSH is low. That's what they're trained in school. Low TSH means that's out of clinical range, means hyperthyroid. But hyperthyroid, your TSH has got to be like 0.01, 0.001. It's like way low. It's not one of these 0.3s, 0.2s, 0.1s. Those are not hyperthyroids. All right, so going back, if you have somebody with a thyroid, a TSH of 1.0 or less, then you want to think about some kind of infection going on. It fits a pattern. It's just like anything else. It's not an absolute. You look for the patterns. What about the ones that are in between, like 1.1? Well, a lot of times I will find that there are multiple things going on. You can find some hypoglycemia going on. You can find some insulin resistance. You can find some other things that are going on. Okay, I want to make a statement real quick before we go on. We are going to have a DABCI seminar where I'm going to go through thyroid function in depth in a 12-hour seminar. We're going to go through all the ins and outs. This is just a taste of what we're going to be going through. And we're going to be doing that. It's in July. And I don't know the exact date. I think it's the 16th and 17th. It might be the 17th, 18th. It's the Friday and Saturday that's kind of wrapped around those days in July. So I invite you to be a part of that. As I said, we'll go through this journey and really give you some great clinical insights on how to walk through this. All right, so that's the hyper. So let's go through a case study. Chief complaint, excessive mucus from the lungs, fatigue, depression, and SIBO. So let's look at some of her numbers. All right, so her cholesterol to HDL, all's good. Actually, cholesterol to HDL is a little low. That shows me some immune dysregulation. That's not for us right now. All right, so, BUN's low, a little bit of liver congestion going on. Magnesium is low. Anytime that magnesium goes below 2.1, we really think about things that fits a pattern of probably some inflammatory stuff. Remember, magnesium is a buffer for acidic blood. It also, somebody's inflamed, they're going to have acidic blood. You're going to use a lot of that. Sodium, is down. So some issues going on there. TSH is at 0.27. She's not on any thyroid medication. C-reactive protein, which is an acute phase reactant, is at 15. So that's kind of through the roof. So her neutrophils are at 70 point, anything over 60 in the neutrophils, we get suspicious of a bacteria. Anytime we have platelets above 250, we begin getting suspicious of some kind of infection. So she has the C-reactive protein of that. So she's got three things on this blood test that's really pointing to infection. And then she has the TSH that's right there. So for me, that would be enough. And plus she has mucus. She's got a lot of congestion in the lungs. That fits a pattern of a chronic bacterial infection in the lungs. She's going to go to a medical doctor. A medical doctor is going to wrap yellow tape around it, say there's nothing to see, because they're going to look at that white blood cell count and they're going to be fooled. They're going to say, oh, there's nothing going on, but there's a bacterial infection going on. All right, so this is what we did. We did some work on her, did some vitamin C, used some silver, high dosages of lipo C. I think we were doing 6 grams a day for multiple days, maybe 10 days. Use some silver and some other things. We might have done a vitamin C IV. But look at the TSH, it's 0.27, now 0.88. So that's a sign that we're starting to move the right direction. Her C-reactive protein was at 15, and now it's at 5. Neutrophils were at 70, now they're at 67. But watch this, very interesting. Now the white blood count raises. I will tell you, if you see a white blood cell count that's 8 or above, you have to be suspicious of an infection. Now, this could also be pregnancy numbers. Slightly elevated white blood cell count, slightly elevated neutrophils. So you got to check that out in a 29-year-old female. But in this case, we know there was infection going on. So to me, her white blood cells were 6.5 or 6.7 before, and now they went up. What does that mean? Well, we used some nutrition to start going after this infection, started getting the infection more under control. Now the white blood cells are saying, okay, man, let's get on. We can do this now. See, before what was going on was the white blood cells were just being beat up, and it was chronic, and they were just laying there, kind of like, that leopard comes and chases the antelope and grabs him by the behind and throws him down, and finally the antelope just gives up, right? So the immune system just kind of gives up there. But now it's like, oh, wow, we've got some life. We're going to continue and really go forward. All right, so the last pattern I'm going to go through right here is this one. This is a 60-year-old female with entrance complaints of recurrent bladder infections. All right, so let's just move on. So she is diabetic. And what do we observe here? Well, we observe some thinning hair. That can be low thyroid, can be low testosterone too. coarse hair, we see that. Lateral third of the eyebrow is diminished or gone, so that's going to be part of that. A little bit of dry skin going on there, so you know, fungal toes, that can be from low circulation. It also fits the pattern of low thyroid. Palpated the thyroid, listened to the abdominals. She has some skin tags, which are consistent with insulin resistance. This is that acanthos nigricans, also consistent with insulin resistance. All right, so this is what we see. So she has diabetes, cardiovascular problems, obviously. I need to point that out real quick. But if you see the discoloration in the legs here, right there, that looks like cardiovascular to me. All right, so here we go. Cholesterol to triglyceride ratio should be 2 to 1. If you have good sugar metabolism, she's 1 to 1, which speaks more of insulin resistance. She's diabetic, so we know that. Fasting blood sugar was elevated, and triglyceride to HDL ratio, sorry about that, to HDL ratio should be 3 or lower, and if 255 to 46, so that's about 5, a little over 5. So she's about double what she should be on that number. Just as a note, the triglyceride to HDL ratio is one of the best markers, that ratio, to really see insulin resistance. But it's a rule in test, not a rule out. You might have insulin resistance and that be normal, but when you see it elevated, it really is a confirmation you're probably dealing with that. All right, uric acid's high. She's pretty inflamed, so we kind of expect that. Now, let's look at some of her numbers, though. All right, so TSH is functionally high. It's not outside the clinical range, so you would not give it a primary diagnosis of primary hypothyroid, but from a functional standpoint, she is a functional primary. All right, so let's look at some of these numbers. Keep in mind, total T4 is 98, total T3 is 106. So I want you to keep those numbers in mind, and let's walk through this, okay? All right. All right, so remember, normal TSH is going to be 1.8 to 3.0, right? It doesn't, you can have normal TSH and have Hashimoto's and have, or you can have normal TSH and have hypothyroid secondary or these other things. So don't get confused there. I'm just saying when you see it there, and if it's the pattern of normal thyroid, it probably is. So when we have secondary, it's 1.2 to 1.8. When we have tertiary, which is hypothyroid, hypothalamus can be lower than 1, right? So the next one I'm going through is this, is going to be a poor conversion, T4 to T3. And here's how you can tell. So pituitary sends down TSH, it hits the thyroid, thyroid kicks out T4, T4 goes to T3, all right? So normal T4 functional is 6.5 to 12.0, right? She was 9.8, right? Now keep that in mind. So normal or functional T3 is 115 to 180, right? So these two numbers are relative to each other, meaning that if she's 9.8, she's more than halfway the other way. So I would expect her to have a T3 of about 160, somewhere in there. If you can see that you're about there and you're about there, they need to equal each other. If it's 6.5, I should see something close to 115. If it's 12, I should see something close to 180. She's 9.8, so 160, you could do the math. That might be a little off, but that's pretty close. Well, she came in at 106. So what does that mean? That means that she did not convert well. So that means that that enzyme that takes that iodine off, something has compromised it. So I'm going to give you a quick list. One is if you have liver congestion. Liver congestion, because the liver convert is where a lot of the conversion takes place. I think 40–50% of the conversion takes place. But conversion also takes place in the GI tract. So if you have an inflamed GI tract, or if you have poor liver function, it can cause poor conversion. Number 3, poor sleep, if you don't sleep well. 4, high cortisol. 5, low magnesium, low zinc, or low selenium. So these are common drivers that will bother that 5' deiodinase. So if you take somebody's T4 total and it doesn't match T3, and that T3 goes down, This gives you a really nice functional differential to figure out what's causing problems. It is for this reason, and there's others too, but this reason will encourage me when I see somebody with a thyroid problem, I use it as an investigation tool so I can really figure out what's going on with the root. Because when I do the full thyroid workup, I can actually start piecing together what is driving other problems. Somebody comes in, they got whatever problems they got going on. As a DABCI, chiropractic internist, our job is to figure out what mechanisms are involved, what systems are involved, and what kind of strategy can we build to help them get back to health and life. Well, when I see a thyroid that's down, I can look at this and I can start piecing together what is causing. So I use the thyroid workup not just so I can help thyroid function, but I use thyroid workup primarily to understand what's at the root of the patient's problem. All right, well, I think this has been fun. Remember, we have, I don't have my phone with me right now, so I have no idea of that date, but if somebody could help me out and shout it out on this thing, that would be great. It's like the 16th, 17th, 18th, somewhere like that. It's going to be July. It's on the Friday, Saturday. We start at 5 o'clock on Friday evening. We'd love to have you come be a part of that. I'm going to look real quick and see if I have any questions that I can actually get to, because I was looking at my questions and I just couldn't see my box very well. So I'll do my best here. And if it works, all right. Well, it said my sound wasn't doing perfect. So, well, you know, if I did this whole seminar, nobody heard it, then I guess joke is on me. All right. Okay, guys, thank you so much for watching this and being a part of this. It has been a lot of fun. We're going to make a recording of this. If you want to go back and listen to this again, I would love to have you have the opportunity to do this. All right. Well, God bless, guys, and have a very great evening. Good night.